Hi students, I am Dr. M. Ashraf Majrooh, Professor of Community Medicine. I welcome you in the learning session of Behavioral Change Theories and Intervention. The highlights of session are what is behavioral change, why we need behavioral change, common behavioral change theories, description of theory and models, trans-theoretical model of change, and behavioral change interventions. Let us start. Let us describe these topics one by one. So, behavioral change intervention are coordinated sets of activities and techniques introduced at given time and place to change the behavior of the individuals, families, communities, population and subgroups of the population. The health of the population and the individual within them influenced by a complex system of determinants from individual lifestyle factors and community influences through living, working and social conditions. So this is the situation why we need the behavioral change. Why we need behavioral change? Health can't be dissociated from the human behavior. It is overall reflection of harmony of human with their surrounding environment and ecosystem. As you know, the ecosystem is disturbed by the human behaviors, and that is why there is air pollution, global warming, deforestation and unsustainable use of resources. This behavior leads to unhealthy planet, and this is one of the reason for the behavioral change. It is hard to name any disease or problem that may not be related to human behavior. Behavioral change is the most effective strategy of prevention in primordial and early pathogenic phases of illness. Behavioral intervention are desired both public health emergencies and routine public health practices. As you know, in COVID-19, this is the public health emergency of international concern, and all the it demands a very difficult behavioral change, that is the self-isolation, social distancing and self-quarantines. These are very difficult behavior demanded by this calamity. So the behavioral change is needed both in communicable, non-communicable diseases and to deal with the risk factor and the underlying risk factors. So let us see some behavioral theories and models in practice. The behavioral theories and models are evolved through scientific research and experiences of the behavioral analysis of the intervention in the past. There are the theories in practice: social cognitive theory, abbreviated as SCT. The other theory is health belief model, abbreviated as HBM. Reasoned action theory, RTA, also known as theory of planned behavior. Self-determination theory, SDT, and trans-theoretical model of stages of change. So these are the 5 theories. We will concentrate and describe these theories. So the social cognitive theory, it was derived from the social learning theory, and in 1960 Albert Bandura was who first time put forward this theory, and this theory assumed that the environment, the person, the behavior influence one another and this process is referred to as reciprocal determinism. So this theory is based on the reciprocal determinism of the environment, the person and the behavior. Let's see how these determinants are interacting. So if we concentrate on the behavioral factors, they are basically modeled or influenced by the internal intrinsic capacities, intrinsic factors, cognitive factors of the human beings. That is, they are based on the knowledge, expectation and attitude of the person. They will affect on the behavioral factors, that is the learning skills, practices and self-efficiency. Similarly, the environmental factors like family, friends, role models, electronic and social media, jobs and income, they affect the behavioral factors. So this triangulated relationship is for all the factors. The environmental factors, they are influenced by the behavioral factor of the human beings and its cognitive factors. And similarly, cognitive factors, they are influenced by the environment and the behavioral factors. So this is the basic construct of the social cognitive theory. And the basic constructs for intervention in behavioral theory are the observational learning, the reinforcement. These interventions will model the behavioral, will change the behavioral factors. Similarly, the self-control and self-efficiency are the factors which are improved with the motivational intervention according to this theory. The next theory is the health belief model. It was developed in 1950s by the social scientists at US Public Health Services in context of TB screening. And this model HBM is focused on the individual perceptions of susceptibility and severity, the disease and the perception of relative benefits and barriers of the preventive behavior. So these are four key pillars of this theory: the susceptibility, perceptions of susceptibility, severity, and perception of relative benefits and perception of barriers. The ultimate goal of the intervention is to alter the individual unrealistic perception. The perception, no doubt, they are based on these four elements, but the perception may be unrealistic and they should be changed through the behavioral change interventions. We can have the exercise for brainstorming of this HBM model on COVID-19 disease. So if I ask a few questions related to HBM in relation to COVID-19 disease, do all the people believe that they personally are at risk for COVID-19 disease? This risk perception is known as perceived susceptibility. Similarly, next question is, do they believe that this disease is serious threat to life? So some may be perceiving that it is very serious. Some may not be perceiving it as serious. So this sense is defined as the perceived severity of the disease, and it varies from person to person. Then do they believe that the social distancing, stay home, self-isolation, self-quarantine can really prevent the COVID-19? This is the perceived benefits. This is known as perceived benefits, and they also vary from person to person, and that provides the room for the behavioral change intervention. Do they believe that they are not blocked from obtaining the stay home, social distancing, self-isolation and self-quarantine by financial, schedule, transport or other concerns? So this blockage from the pressure of the uh, financial pressures or other concerns. These are the basically barriers, perceived barriers, and they have also different meaning from the different persons. So, in for the behavioral change of COVID-19, these four pillars have to be addressed, and some reminders, reminders are required socially for social distancing, stay home, and self-isolation and self-quarantines. These actions are known as prompt signals. So prompt signals are required, but they are for at all four levels. So let's see the graphical picture flow diagram of the health belief models. The health belief models, as it has been described, it is again on those four pillars. But these two pillars, perceived susceptibility, perceived severity, it varies with age, gender, social classes. Some classes, they believe that this is the disease is very serious and they are at the risk, and some people they don't believe, they don't take it serious, and this depends upon these demographic factors. The other psychosocial factors, the personality, peer group, role models and family norms, they also alter the perceptions regarding susceptibility, severity, perceived benefits and perceived barriers. So for all these need the health motivation, and that may leads to the desired actions, and the prompt signals are also required in this model. If the intervention based on this model may be the sensitization for the perception of susceptibility and severity, and on the other hand, removing the barriers through sports and motivation for the perceived benefits. These will enhance the action, and moreover the appraisals and encouragement of the desired action will also prompt these healthy behaviors. So this is the health belief model, which is very applicable for sensitization of perceptions, motivation and removal of the barriers. The next model is very interesting. It is known as theory of reasoned action, TRA, and it is also known as theory of planned behavior. It assumes that the people's behavior is predicted by subjective norms, mean intention to behave, and the normative beliefs, that the beliefs about whether the other people approve or disapprove the intended behavior. So this model basically based on two things. One is the subjective norms, mean the intention of the person to perform a certain behavior, and the other pillar is the normative beliefs, that mean how the other people perceive that behavior. So these two things will model the this behavior, and this theory was put forward by the uh, Lysick and Isaac in 1980. The behavioral theory, as I have already explained, the subjective norms, they are influenced by the normative beliefs, and they in turn determine the intended behavior. But to alter the intended behavior, the motivation to comply and perceived behavioral control is required. And the actual behavior, intended behavior, needs to be altered as it is desired. So the resultant behavior, actual behavior, will be dependent upon the level of motivation and perceived behavioral control uh, uh, for the achievement of desired health behavior. So the behavioral beliefs, attitude towards the behavior, and then normative beliefs, the perception of the other people about the subjective norms, and they will model the behavior. This is the basis of this behavioral change model. We can apply this model on the next model is self-determined, next theory is self-determined theory of behavioral change. This theory was put forward by Edward Deci and the Richard Ryan in 1985, and it is mentioned in his book Self-Determination and Intrinsic Motivation in the Behavior. This theory states that the human behavior is outcome of self-competency, relatedness, and autonomy of the performance. And these are the determinants of the behavior. And what are the meaning of these keywords? The competency mean the people intrinsically need mastery of the tasks and learn skills to achieve successes in the life. And what we mean by other keyword, relatedness, people need to experience a sense of belonging and attachment to the other people. And the autonomy is another keyword. People need to feel control of their own behavior and goals. So these three elements, the competence, the relatedness, the autonomy, they model the behavior in according to this theory of self-determination. So it is interesting to learn what is self-determined and what is non-self-determined behavior. Purely this is the continuum of the two extremes. On one extreme is the pure self-determined behavior, high level of motivation. And the other extreme of this continuum is non-self-determined, low level of motivation. And people mostly fall in between these two extremes. And this model states that the intrinsic motivation and self-determined motivation is influenced by the extrinsic motivations. The intrinsic motivations, as I have explained, they are determined by these three components: the perceived competence, the perceived autonomy, the perceived relatedness. They are in turn, the autonomy supported from the environment and relationship. The competence is also supported from the environment and relationship, and relatedness from environment and relationships. So all these three interventions, they will support the perceived autonomy, perceived competence, and perceived relatedness. So in this model, the basic idea is to change the intended behavior through extrinsic motivation. So what we need is extrinsic motivations and the positive feedback. These intervention will remodel the desired behavior under this theory. And we have to channelize the personal autonomy and competence and the relatedness. This intrinsic behavior is channelized through the extrinsic motivation. So this is the key lesson in this model. Now, how we can apply this theory of self-determination in physical activity? For this, in this, the personal determinants include, personal autonomy includes the motives, the attitude of the person for physical activity and exercise, and the choices available. These are the perceived autonomy factors. The perceived competence factor is the knowledge, the self-efficacy. These are the perceived competencies. Then perceived relatedness, the social support from the other people, perceived empathies from the other people. They are the perceptions of the relatedness. The positive physical activity related effect are the motivation and reinforcement from the uh, people and the organization. The environmental factors which are required for to support this physical activity are the interpersonal social support and activity, family, home commitments, and social norms. Then organizational support for physical activity, the scheduling, the physical workload, driving organization policies. These are the organizational factors that support the sense of physical activity. The community, residential location, and monetary cost of the activity of choice, they are modeled by the community. So the personal determinants, the environmental determinants, both leads to both are influencing the behavioral activity level, and they are also the intrinsic factor, the sleep, fatigue management, the diet and nutrition, and time management. These are personal to the people, and then these factors, they will support the health related behavior, and then it will improve the quality of life. So this is by the use of theory of self-determinations. Next is the trans-theoretical model. These are basically the stages of change. The TTM was developed by Proshika and DeClement in late 1970s. The trans-theoretical model is based on the psychotherapy experience. People appear to go through similar stages of change, no matter what kind of intervention they undergo. And this is the integrated biopsychosocial model to conceptualize the process of intentional behavioral change. So whatever the behavior is intended, it is passing through certain phases. The TTM seeks to include all the integrated key constructs from the other theories which I have described into a comprehensive theory of change. That is why it is known as trans-theoretical model, and this is actually based on all the theories, and it integrates all the theories. It consists of 5 stages. First stage is the pre-contemplation, and second stage is contemplation, third stage is preparation, and fourth stage is taking actions, and fifth is maintenance, and sixth is the relapse. The standard times for these stages, they are also mentioned. The pre-contemplation phase, non-readiness phase, the person will not be ready for the desired action in next 6 months, and in contemplation stage, the person is ready in next 6 months, and the preparation The person is just ready within 1 month, and the action is now on way, and the maintenance phase may last for 6 months, and the relapse at any time. The literary meaning of these pre-contemplation mean no readiness, and contemplation mean the readiness, and preparation mean to get ready, and action mean to take action, and maintenance mean to keep the action on, and relapse is undesirable effect of the change. Now we can see how they are interrelated with the motivational interventions at all stages. So the first stage in TTM is the pre-contemplation. It is known as unaware of the person is unaware of the problem, and in second phase, aware the problem and desire to behave the change, and desire to behavioral change. Then third stage is preparation, intended to make the action, and action practice the desired behavior, and maintenance work to sustain the behavioral change. So what the interventions, how they are linked with the interventions are required at each step. At first step, the needs to create the awareness for the change of values and beliefs, and this is the at this stage of interventions are required like this. And on the contemplation phase, the persuade and motivation is required, and then educate and counseling, technical support is required on the phase of preparation so that the action can be executed. And when action is executed, the facilitate and enable the action. And lastly, the reminder for communication and reinforcement to maintain these actions so that the relapse, the sixth phase, may not occur. That is the phase of relapse. To prevent the phase of relapse, the reminder of the communication and reinforcement is required. So these are the basic theories behind the behavioral change interventions. So let us see what we need for behavioral change interventions. The behavioral change interventions include the motivational interviewing. This is the interpersonal communication, and the steps for this interpersonal communication is to express the empathy with the person and through the interpersonal communication and interviewing, and then explore the discrepancy between the intended behavior and desired behavior, and then roll the resistance, mean to remove the resistance, to remove the discrepancy between the intended behavior and the desired behavior, and then support for the self-efficacy. This is the very good intervention, and it is through the interpersonal communications. The more interventions are the educational curricula, design the curricula for desired behaviors, and include the public health problems through collaboration with the education department, and implement the educational policies with the collaboration of health department for the conducive behavior to health. So this is the intersectoral approach of behavioral change intervention. Then using targeted electronic media, we can design the behavioral change messages, and then we can disseminate to all those where they are the target populations, and these targeted electronic messages, they are very effective to change the desired behavior among the selected group of population. Use of mass media where primordial preventions are required than TV screen media, social screen media to address the mass population. This is the most effective intervention. Then we can use the targeted print media. The print media like posters, pamphlets, cards, leaflets, they can be used even in the interpersonal communications, and they are also used for dissemination of the messages to the target group where the literacy rates are high. For more literate, the print media needs a high level of literacy. So these are the behavioral change intervention generally used. So the summary and the conclusion, all health related states and events are associated with human behavior. The behavioral change theories and the models provide a sound basis of behavioral change interventions. Motivational interviews, educational curricula through intersectoral approach, and the use of media are the effective modes of behavioral change intervention. So thank you for listening.